Welcome, everyone. I'm Alexander Blunt, and I am the curator of a series of webinars on behalf of the National Center for Behavioral Health Integration. Today, we're going to be talking about the role of behavioral health integration in enhancing workforce resilience in primary care. And workforce resilience has become one of the more important elements in delivering care in the face of the pandemic that we are still coping with. We are going to be presenting for about 3/4 of an hour, and then we're going to have questions and answers. So if you would hold your questions. Also, if you would put your questions in the chat, I'm sorry, not in the chat, in the Q&A at the bottom of your screen. There's a little icon for Q&A. If you would put them in there, then I'll be tossing them up to our panelists when it's time for question period. Our panelists today are two well-known and highly qualified psychologists. Craig Sawchuk is co-chair of the Division of Integrated Behavioral Health and professor of psychology in the Department of Psychiatry and Psychology in the Mayo Clinic. Christine Runyon is co-founder of Tend Health, a now national organization providing wellness support and therapy to providers of care around the country in this pandemic time. She's also a professor in the Department of Family Medicine and Community Health at the UMass Chan Medical School, where I also worked with her for many years. This series of integrated behavioral health webinars is almost done. We've done 5. We have one to go on the 26th of this month, where we'll talk about the other workforce in primary care, the community health worker and we would call them non-professional, non-licensed clinicians who can make all the difference, particularly for complex patients. And so I think you would be delighted to come to that one. And since you registered for this webinar, you will get an invitation to that one. Let's go on. This is our conflict of interest disclosures. Not going to spend much time with it. Our emails are at the end. And so if you want to take down an email and reach out to any of us further, you're welcome to do that. Let's start by saying what is obvious, I think, to all of us, and that is that the pandemic has been a workforce disaster. This came home to me, particularly in the spring of 21, when I was teaching a course in primary care behavioral health leadership. Had a group of people who were directors of integrated behavioral health from places around the country. And we were talking about retention in the workforce. And one of the folks in the course, who was a director of behavioral health in a very large health system. This is a health system with 112 primary care sites in 8 states. And he reported that in the 6 months previously, 3 months of 2021 and the last 3 months of 2020, his workforce of approximately 60 behavioral health clinicians had lost 30%. That was very striking. And the follow-up he offered was that he was in the middle of a study using focus groups of the people who stayed. What was it that kept those folks on the job in the face of the same level of pressure as the ones who felt they had to leave? And when the studies came in, the results came in and were combined with what he learned from exit interviews, what he found was immediately endorsed by the other behavioral health leaders in the course who had had a similar experience in attrition that was related to their multi-site programs as well. What sorted the stayers from the leavers was the level of integration of behavioral health in the practice in which they worked. The stayers reported that they felt understood and appreciated by the practice, by their managers, but even more so by the PCPs, that they had significant interaction with the PCPs in which their opinions and their knowledge was pivotal to the design of care for patients. That as the pandemic hit, as the stress mounted, they were asked to contribute their knowledge to designing ways of supporting fellow staff, fellow clinicians, but they were not asked to be therapists to their colleagues. And they were treated by administration as if they also were under a great deal of stress, and that they also needed help with self-care. Now, this isn't completely out of the blue, that we have some pretty good evidence already in the study of enhanced teams, but the evidence that we have has been focused on physicians, on what helps physicians avoid burnout, what reduces physician attrition in primary care, because we know there's been a great deal of it. What was found was that the team culture made all the difference in who stayed and who went, or who felt they were working at the top of their skills and who felt emotionally exhausted. And the consistency of membership of the team was a core element of team culture. That seeing the same faces regularly, that having the same folks to bond with, to build trust with, to be able to solve issues or misunderstandings with, created a culture that was supportive to physicians, and that when physicians felt supported, they were more likely to be flexible in relation to team leadership. That in enhanced teams, the hierarchy tended to be flattened. Leaderships tended to be situational, so that the person on the team who had the most knowledge related to a particular situation with a patient would be likely to be listened to, would be likely to be leading the discussion of the next step at that point. And that flattening of the hierarchy involved staff members generally in core elements of treatment, not just bringing somebody into a room and taking their blood pressure and preparing them for the physician to do all the work. That there were important pieces of work that each member of the staff contributed, and that contributed to better patient satisfaction, stronger culture, better job satisfaction for physicians and staff. So we have this data already. It sounds like integration is going to be another element in describing high functioning teams, but this is anecdotal in my experience. It may be anecdotal in everyone's experience, but right now we have two leaders in the area of workforce resiliency who have broader experience than I do to talk about their experience and knowledge in relation to integration and workforce resiliency. And we're going to start with Dr. Sawchuk. Craig, take it away.
Great, thank you so much, Dr. Blunt. And we're gonna, with both Dr. Runyon and myself, we'll try to help move from feeling more to fact around the benefits of integration. But before we get started, I just really want to say thank you to everybody, not only for attending and supporting integrated behavioral health across the board, but also just all the work that each of you and your teams have done in really being innovative and trying to support not only our patients and designing and developing new models of care, but also the teams that you work in very well, because as you'll see and hear some of these recurrent themes of just that sense of community really helps us get through very, very difficult times. Now, I also want to extend my sincere thanks to the multidisciplinary team that I have here at Mayo Clinic, and we're an enterprise-wide division, but are just wonderful and talented social workers and nurses and prescribers and psychologists and our primary care, family medicine, and pediatric teams, our administrative and support staff. When you really think about these, the multidisciplinary groups each has their own really cool and unique talents that have all had the same positive outcome. Dr. Blount, if you could go back there for a second, because we're not done with Queen and David Bowie yet. So, so I guess that if you don't like classic rock, this might be a difficult presentation, or at least my part of the presentation to listen to. But we've been under just a tremendous amount of pressure throughout the course of the pandemic. When the pandemic hit, there are a lot of new onset stressors. We're all marinating in uncertainty, really in all aspects of our lives. So that wasn't just like our professional lives, but our personal lives, our social lives as well too. And we were caught in this weird purgatory of sometimes not having enough information to make decisions, and sometimes being fed almost like too much information. And if you think about like how the brain actually works, at baseline is just hardwired for threat. And throughout the entire course of the pandemic, we are just automatically attentive to all this threat all the time. And as we're trying to navigate both survival and trying to make some semblance of a new normal, just that stress and that uncertainty acts almost like an erosion, type of effect or erosion type of process that just makes us more vulnerable. And the stressors and the losses and the uncertainties that our patients experience are also similar to what our teams experience as well too, and what we experience as well. Our clinicians and our healthcare colleagues, we're human as well. But if we can go to the next slide. When we just try to look at where we're at and kind of looking ahead, it's always helpful to take a step back and just a very, very brief touch on this. Prior to the pandemic, about 1 in 5 individuals have been dealing with a mental health condition. But when the pandemic hit, kind of like the great amplifier, in comparison to pre-pandemic times, rates of stress, anxiety, depression, insomnia, trauma have grown anywhere between 2 to 4 times the prevalence. So these are even more common now, and we certainly don't need a clinical psychologist explaining why those different conditions are being all amplified now. But we also know that certain segments of our population and demographics are at even greater risk. Healthcare providers being a major one of those, but then also we always have to remember that those that are underserved in our communities and the most vulnerable pre-pandemic have also borne the brunt of that over the course of the pandemic in terms of increased rates of distress and even more difficulties to accessing care. But let's go to the next slide as well. And being in healthcare, it really is a tough gig. When you think about it, it's an honor and privilege to be in this position that we're in, with being able to be in service of others and to be able to help others. So that, honestly, there's no better time on the planet to be doing the kind of work that we do during pandemic times. However, pandemic times are not normal. And as we just alluded to, the same stressors and losses and uncertainties that are the patients that we serve and the teams that we serve are dealing with, we're dealing with as well too. So next slide, please. So pre-pandemic, healthcare providers are already at risk for a lot of these things. You know, all these traits and qualities that help us to be good in service of others and be innovative and work in teams and collaborate. They all involve that empathy and compassion and being super thoughtful and introspective. But once again, we are human too. So even prior to the pandemic, healthcare providers at all levels have been at risk. And then if we think of, once again, the pandemic being the great amplifier of this, we've seen all these rates increase as well too. And certainly healthcare providers that have been on the front line and have borne witness to the tremendous losses and stressors that we've experienced have been at even more risk. But we'll go to the next slide as well. So I want to talk a little bit about this timeline of disintegration, which is not an uncommon theme or story that any of us that are on the call today and our colleagues have actually gone through. So this is a very, very similar set of scenarios. And I think one analogy that we really held on to was we're building the plane in flight. You know, we've got some materials, we've got an infrastructure, we've got a program, but we had to completely redesign and repurpose everything. I want to talk just about a couple of points here. In late March, one of the rallying cries that we had when all of our med specialty and surgical services shut down at Mayo Clinic Rochester, it was primary care, family medicine, pediatrics, and the ED that were keeping the lights on at Mayo Clinic. So for the one rare time, primary care was in control and really continuing to serve our patients and figure things out. But also, you know, during crisis times, and again, I think this is probably something that we can all reflect on in our own programs, as we all collectively were scrambling around to figure out how we can be innovative. But, you know, in times of crisis, institutional inertia kind of goes away. So you have this opportunity to do really cool things and really try to be innovative and really try to figure this out. And some of the basic ethos of being in integrated care is we're used to being innovative. We're used to trying to figure out novel and new ways to do population health and to try to apply new technologies and other things. So again, as I'll talk about, you know, over the next couple of slides as well too, the very nature of doing this kind of work actually had us well positioned to be able to start to bridge those cares. So when we think about what actually worked, again, it gets back to this idea of being in integrated behavioral health. What we do and do best, communicate, collaborate through huddles, curbside consultations, this helped absolutely enormously to kind of maintain that sense of connection with each other, especially even when the pandemic hit and most of our colleagues actually went home for a period of time. We still had a core group that was here. We also did a lot of work around adapting our huddles with our primary care colleagues. For the primary care leaders that were still here, we were still meeting in person and being socially distanced, but then we were able to leverage the video platform as well too, and work a little bit more closely with our teams. And this idea that we could also leverage that technology not only from the administrative community perspective, but also it allowed us to work together and collaboratively to build those bridges to patients, to be innovative in developing care. And the sense of community kind of being in it together. I know our new department chair of psychiatry is military trained psychiatrist in the Navy, and he talked about this concept of battle buddies. So we're kind of all in the mix together, and the very nature of being in integrated behavioral health and in primary care, where we're just part of the primary care team, is that we have each other's backs. But again, this all predates the pandemic. Just the pandemic created this context and the circumstance that allowed all the basic ideas of doing integrated behavioral health work to actually work to help keep us together, to innovate, and to keep going forward. So if we can go to the next slide. I'm a big fan of Don Meichenbaum and all his work around stress and trauma. And remember, bad things happen to good people and good communities all the time, but the natural trajectory is towards resilience. And there are lessons learned in the face of really horrible things. And of course, none of us ever wanted a pandemic to hit, but also look at what it's taught us. Look at the things that we've learned. Look at the innovations that we've been able to make, like, for example, redefining new goals. So many of us who didn't have video visit capabilities have been pushing for that for a while. The pandemic made it happen in less than 2 weeks. Staff retention and expansion. This is, to the point of what Dr. Blunt was making a little bit earlier on, is that in the Department of Psychiatry, we have multiple divisions, and in many of the other divisions, they actually saw an attrition in staff for a variety of reasons. I know many folks have also been experiencing that. Over the course of the pandemic, we only lost 2 folks that were took on new jobs. We were immediately able to refill those positions, and in fact, we're in expansion and growth mode with being able to gain additional incremental slots to help meet the mental health needs. And that ability to maintain our staff really has a lot to do with, again, the basic premise of and the DNA of what you do in integrated behavioral health. So it's those kinds of things that help ensure stability going forward. And I'm talking about this not only integrated behavioral health with the mental health providers, but with our primary care, family medicine, and pediatric teams as well too. It really is this umbrella concept because we're all involved in that care, we're all involved in that community. And we've also learned that flexibility, we can actually do our jobs differently. We can do them more remotely. We had done a pilot exercise prior to the pandemic about being able to deliver remote social work care to folks in smaller EDs in Southeast Minnesota. Boy, did that pilot research help us out in working with our primary care colleagues when they're doing video visits and they need a triage coming in. So I'm just going to end with my time with Neil Young. If folks haven't picked up on my accent, I am Canadian, so got to end off on Canadian. But knowing that we've been through a lot of experiences together, but there's phenomenal lessons that have been learned here. As difficult as they are, they've helped us to advance our practice, galvanize our teams, and do good things for our patients. So with that, I'll turn it over to Drs. Blunt and Runyon with any questions or even comments or reflections on this.
Well, I just wanted to underline something you said at the end and make sure I understood it, which was that for behavioral health clinicians and for other folks, the retention was noticeably better in integrated settings than in specialty settings in your Department of Psychiatry. Is that a fair statement?
That is a fair statement, yes.
Very clear. Thank you so much. Tina?
I do. It's sort of a combination. So I was really struck by what you shared on one of your slides, Sandy, around that the integrated behavioral health clinicians were not expected to be clinicians to the staff and other providers. And, underneath that is this recognition that they were having massive exposures too, both in their professional lives and in their personal lives, and really recognizes the idea that no matter how much knowledge you have, when something like this happens, you sort of can't outrun our own evolutionary biology, right? We can't outrun that we're having those same stress responses. So I'm really curious in your environment, Craig, if you felt like that tenet was carried out in your integrated care teams, and if you felt like that was protective as well.
Yeah, it's such a great observation, Dr. Runyon, and actually, as a little qualifier for the comment on Dr. Blunt's earlier slide, is that integrated behavioral health is really responsible for our community colleagues who get their primary care, family medicine, and pediatric care at Mayo Clinic, but also our employees, which also include our staff members, as well too. And all of us know how hard it's been to be able to find that upstep level of care when somebody actually needs to move from kind of wellness, stress management, to where they're in need of actual services. So being able to be positioned to walk both of those lines, during pandemic times, to be able to serve our employees, some of them obviously in primary care, others in other parts of the institution as well. But being able to have a system that's already designed to be able to support our employees and being able to adjust that intensity of care depending upon what they need has also been extremely helpful, because this is a time when people have been extremely vulnerable to burnout, to losses, to new onset mental health conditions or relapsing mental health conditions. So being able to try to maintain a quote unquote healthier workforce who is present is absolutely essential during this time. And again, we're not out of the woods, yet. We're still navigating through these various things. But what we've learned early on, even though in many ways it's been a trial by fire, we're learning additional ways to help, serve our population better going forward.
Thank you. So, Dr. Runyon, you have been involved in creating an organization in response to this need. And I was at the first national webinar that you gave and was amazed that there were, 900 people who showed up from all over the country. The need and the yearning for some kind of help and support is certainly dramatic. If you would please take it from there.
Yeah, I think that really speaks to the threads that I will try to braid together, I think, in both what you shared in the beginning and what Craig shared as well. So the poet Emily Dickinson wrote, "Hope is the thing with feathers that perches in the soul and sings the tune without the words and never stops at all." And that's very much how I think about resilience. I think resilience is this innate capacity that sits quietly inside all of us and awakens in times of challenge and in stress. It's not something that we get, it's something that we grow. And under the right conditions, we all have this capacity to grow resilience. The conditions are the secret sauce. And I really believe that healthcare professionals are highly resilient, and there's some research that bears that out. I think, to Sandy's point, a lot of this research has classically been done in physicians, but I think it generalizes to other health professionals. You've had to be, in order to become the kind of clinician that any of you are, you have had to face any number of obstacles and challenges to get there. So I'm not concerned about a low resiliency factor in our workforce. I am concerned, however, about the conditions in our healthcare organizations that may not allow that resilience to grow. And, you know,
did I advance it too fast?
Well, and people can, I'm sure, read the quote. I'll just sort of echo on this, that the poet or the author and palliative care physician Rachel Naomi Remen writes, the expectation that we can be immersed in suffering and loss daily and not be touched by it is as unrealistic as expecting to be able to walk through water without getting wet. And you can go to the next slide. And I think that just encapsulates this experience that does predate the pandemic. We have a lot of focus on growing technology, advancing algorithmic-based evidence, medicine-based care in our healthcare systems, but we don't have a lot of attention and caring for what truly is the most precious resource in our healthcare industry, which are the clinicians. And we are training people. Some of this is really our training pathways that focus so much on medical knowledge. They focus on clinical expertise. They focus on procedural expertise. But for many of us, historically, and probably still somewhat now, that fourth leg of the stool is given very little time and attention, which is how do we attend to our inner experience while meeting this suffering and loss daily, no matter what specialty you're in. And so I have been thinking a lot about, and Craig alluded to this, when I think about resiliency and I think about the sources of stress and the opportunities within the pandemic, I think about it from perspective of the hardware and software we're all running in terms of our stress response and the culture, the inner culture that creates, and that same parallel process for our healthcare institutions. So all of us are resilient. We do have the capacity and almost the need to experience some kind of stress or adversity in our lives. You know, I liken it to sort of these pictures of the bucket. The pink bucket is just kind of like, you know, not being of use, not being of service. That doesn't feel so good, a little lost and abandoned. You know, we want to all sort of be in a place where we still have a little room in our bucket, can fill up, but we could also maybe just throw some water out and be a little playful. We have that capacity. That is a place of resonance and coherence for our internal nervous system to sit. But through the pandemic, most of us have looked and felt somewhat like this other bucket, which is we are trying really hard to hold all the water that's coming at us and still coming at us, but we're rusting through the bottom. And we're not able to hold it all in a way that feels effective for us and our families and our loved ones and our professional lives. And that is a function of what we call allostatic load, that our bodies will absorb this stress. And that is the process in which we become stronger. But when you have stress that it is unremitting, it has been so intense at various times. And so you've had this chronic stress peppered with these episodic surges, and our bodies aren't able to hold that. So there's some end system breakdown that happens under this allostatic load. Whereas individuals, we are much more likely to go towards what we want than what we need. We may need sleep, we go to caffeine. There's a variety of different ways that shows up. We may need movement in our bodies, we go to Netflix, binging and laying on the couch. And our systems do this too. Our healthcare systems are much more likely to begin some process of doing what they think is sort of wanted, not perhaps what is needed. So go to the next slide, please. So how and why can integrated care enhance resilience? Next slide. So there's been some research related to the occurrence of burnout. Again, this predates the pandemic, but sort of within the pandemic. And I want to talk about this because so many of us go into healthcare because we want to be of service. We want to do some good. I met just a very green nursing student the other day, and I said, "What drew you to nursing?" And she said, "I want to help people. It's going to bring her meaning and purpose." And that is in and of itself not so effective for reducing burnout. What is effective for preventing burnout and mitigating burnout is feeling valued by an organization. And so they're correlated, but they're not the same thing. Purpose is personal. It's about what population do I want to serve? Am I working with an organization who has a passion and a mission for covering that same population in a way that feels value aligned? It has to do with your ongoing commitment and dedication to the path. That's personal. Feeling valued is about a collective. And if you've heard one thing consistently through this entire webinar so far, it has to do with connection. It has to do with that sense of social support. And these are the things that were protective in keeping people from attriting, and what Craig talked about really kept people thriving in his work environment. Being value is collective, and it's a top-down proposition. That's something that the organization is responsible for, creating a culture in which people feel seen, people feel appreciated. There is some mutual trust, and there's some autonomy. And I loved that finding, really, that behavioral health clinicians were not expected to be the clinicians for the staff, and maybe even weren't expected to not be buckling under that stress. Maybe that's true too, that there was some ability to be vulnerable and say, I'm suffering too. With all the knowledge that I have and all the skills that I have, it doesn't inoculate any of us from the experiences these last 2 years. And so can the organization actually absorb that instead of putting more and more on individuals who are supposed to have it all figured out? So next slide. We know when any kind of trauma experiences, sort of small trauma or big trauma, the number one thing people want, really, probably think about, what do you want most? Is the presence of a loving, compassionate someone beside you, maybe even a hug. When bad things happen, we come together. We come together at small micro levels, and we come together at macro levels. And it's protective because of this sense of not just having a purpose, but feeling valued in a particular way. So when organizations can create that, and it's endemic to the model of integrated care, we don't even have to work so hard to a lot of the points that Craig was making. It's endemic to the model of integrated care. It is a team-based proposition, and that is why it's so protective for reducing burnout. Because when we can create that sense of coming together, we are combating this other part of our nervous system that's wired for fear and threat, but we're leveraging this other part of our nervous system that's wired for belonging and safety. You can go to the next slide. So we talk a lot about our stress response that's here that increases that allostatic load, but we all also have another part of our nervous system called the affiliative nervous system. It's our tendon befriend response. And it may sound a little saccharine, but it has some good evidence from neuroscience that this part of our nervous system, instead of being mediated by norepinephrine, epinephrine, adrenaline, this part of our nervous system is mediated by oxytocin and by dopamine. It's that come together and feel good hormone combination when we leverage that part of our nervous system that allows us to settle and allows us to basically be in much wiser choice individually and as an organization. So when organizations can be working through a lens that is around how at small and large levels do I leverage this affiliative nervous system that's all of us are running. It is our source code. We all have the same hardware and software that are running, and it's a matter of the conditions. It's a matter of the conditions that are dialing up and down which knobs underneath the skin for us as individuals that's going to create that culture in an organization. So I'll go to the next slide. So when I really think about how do we tap into this innate resilience that I know exists in all of the health professionals, in each of you, and all the health professionals that have been working across the pandemic, I think about it from a place that really is around trauma-informed principles. So we often think about trauma-informed care to an individual, and how does our primary care clinic, our integrated clinic, operationalize these principles of trauma-informed care And it's that next layer that I'm really thinking about of like, how does the organization actually manifest and embody these principles of trauma-informed care? And we saw so many of them in different language in the data that was presented by Sandy and Craig around people have to feel physical and psychologically safe. We're creating those conditions with an eye towards patients hopefully in our healthcare organizations. How to create that through the lens of the clinicians. That's that sense of how can a behavioral health clinician feel safe enough to say, I too am experiencing this. The sense of predictability, that is the word I think you used, Craig, in your presentation was around consistency, right? Consistency and trust. So that actually falls into the physical and psychological safety. A sense of predictability, a consistent team, consistent people I'm working with, it builds that trust over time. It also means your brain does not have to work so hard as a forecasting machine to wonder about how to communicate with somebody around a shared patient. Is it okay to interrupt them? Is it okay to sort of exert my opinion on this matter? Is it okay to take the lead in this? When you have consistency in a team and you have predictability, your brain does not have to work so hard to try to forecast out how is this interaction going to go. You just settle into a working way of leveraging each other's expertise in that interdisciplinary space that integrated care provides so well. A sense of agency and control. So that I had a surgeon who I worked with who was cross-covering in the first wave of the pandemic and going in, and I remember she said there was no roles and no rules because none of us knew what we were doing, and the hierarchy flattened. I think, Sandy, you mentioned that too, that it relied on situational leadership. Who is the person in this particular instance who knows the most, who has the most capacity, who can act in this moment? And that doesn't happen in healthcare really any other time, right? The hierarchy is so evident. And so for people to feel like they have some agency and control to be creative, to be generative, to be able to assert themselves in that way. And she said it was in terms of that work of coming together, of belonging around a shared goal, and to have that hierarchy flatten. It was actually a really defining time in her professional life to know that that was possible, and anchored her more into her colleagues and into the institution. And then the sense of social connection and belonging, which I don't think I have to say much more of because everyone's already talked about that and how integrated care provides that, just again, as part of the proposition of working on interdisciplinary teams. And then the final one, I do think is important for leaders. If you are leaders, whether you're a leader of one or you're a leader of 1,000 in this space, I don't think we do a great job of this in healthcare. This is a lot of what I'm seeing on the back end. We don't bake in recovery time at an institutional level, and thinking about this in integrated care when the need has skyrocketed, it also means the need for recovery follows right along that same arc. And as leaders to really intentionally build in some recovery time for the clinicians. So I'll just very quickly go to the next slide. When we can do these things, we are creating the conditions that allows innate resilience to flourish. We don't have to teach people a lot of new things. We just have to create the conditions where we can begin to pay attention, not just to what's going wrong and what the problem is, but turn our attention, incline our mind towards the things that we're doing well, the ways in which we've been able to be generative, creative, innovative, and curious. And that will allow for all of us individually and collectively to rest in gratitude and eventually kind of be in awe of what we've all been able to achieve through this pandemic and how we've been able to do it through coming together into this tapestry of connection and belonging that I think will continue to propel integrated care as the only way to provide primary care into the future. Thank you.
And thank you. I want to apologize for continuing to go back and forth on the slides. I kept getting ahead of myself because I couldn't find a way to turn on the Q&A and those kinds of things without advancing the slides. On the other hand, here we are. Craig, do you have a comment or question you'd like to present to Tina, and then we'll go to the Q&A and begin to address those.
Well, just, you know, I was thinking you kept advancing the slides ahead of Dr. Runyon's presentation because you're just like really excitable and really wanting to see what was coming next. So
right.
It's like really, really good stuff. So I'll take that reframe. Yeah, so a couple of, you know, one comment and then just a brief question, Dr. Runyon. One of the things that you mentioned there right at the end, that healthcare, and it's almost like the business side of healthcare doesn't do too well, is the recovery time. And this is something that we have been talking about for months. Like, this is coming, you know, as things quote unquote settle down. It's not like we're at 100%. And starting, people are worn down already, so that vulnerability is still there. So once again, being Canadian, when I'm talking with primary care leadership around this, I say, think about like hockey. You go as hard as you can for a shift. You have to come off and sit on the bench for a while. You got to rest. So we got to really be thoughtful about building in some time away. You know, getting away, and I know that's a schedule management thing as well too. But the importance of folks using it, because geez, all of us, all the colleagues we work with, nobody used all their planned time off over the pandemic. It's all been kind of carried over, in some cases lost. But one question or thought that I had for you, I really loved when you differentiated purpose being personal and then valued being collective, and really the importance of the institution taking ownership over that and how they communicate those values. So what are maybe some best practices that you found with institutions in the course of that pandemic of being able to communicate out and demonstrate those values to their employees?
Yeah, I think it really comes, certainly words feel nice in terms of like email messages that, you know, thank you and you are appreciated. But ultimately, I think it actually comes, I'm going to integrate your previous point. I think if you want to know what an institution values, pay less attention to their memos and more attention to their budgets. That you will actually see the values reflected in where they're willing to put, you know, some funding. And that does have to do with the business of healthcare, and to trust that baking in that recovery time, limiting people from taking, you know, sort of, people can get paid, get a lot of overtime money, extra shifts, but having somebody really keep an eye on and not allowing some of that to happen, to trust that baking in and insisting in some ways on that recovery time will actually serve the institution. I mean, our healthcare institutions are hemorrhaging clinicians because of that exhaustion, because of the lack of rest. People are leaving, not because they never want to do the work again. Literally, they'll say, I just need to pause. Right? And there's not a way in my current context in which I can do that other than a medical leave, or significantly reducing clinical time, or leaving. And so to have leadership and institutions see that recovery time truly as a short-term, perhaps budgetary hit for a long-term investment. The cost to recruit a physician, you know, is estimated to be $500,000 to $1 million. That's what it costs for a physician to leave and to get somebody back in their place. So it costs a lot less to insist that somebody actually takes some recovery time. Yeah.
Thank you. So we have a couple of comments and questions. Dr. Burdett, whom many of us know, says, we found significant behavioral health workforce challenges across traditional outpatient services has led to IBH taking on patients for longer terms than the scope of the model. And in other words, we had to change what we did. And in the process, coping has not gone well, and we lost over 50% of our workforce. Do you have a sense of that as confirming the theory that we're talking about? And do you have anything that you would suggest that, for instance, Dr. Burdett takes to her leadership in building resilience and the ability to gradually grow the workforce again?
Yeah, it's such a important point that Dr. Burdett shared, because this isn't an all or nothing type of experience that just because you're in integrated behavioral health, therefore you're protected, and therefore it maintains that. The things I've always been impressed by integrated behavioral health models is they have all of the models, regardless of where they're from, they all have similar qualities. They're physically embedded in primary care, that there's options for patients. There's a lot of non-visit care activities that happen to manage the population. It's time limited. There's measurement-based care. So there's all those elements, and then how it's constructed and played out in different practices will vary, and then also the populations by which they actually serve will vary as well too. So I really appreciate this comment coming forward, that it's just because it's IBH doesn't mean that everything has gone well. And some of the things that we have found, one thing I really can also reflect on, as we all can, is the quote unquote backwash, the time limited model, because so many of those higher step options either weren't available, or the wait time to get to those has been incredibly challenged. That's pushing patients that are needing longer term care back into primary care, because our primary care, family medicine, pediatric teams still have to care for them. So I can totally understand, like, our wait times are extended out, which is really unusual and not part of our model, but we're doing the best that we can with that. How it's being incentivized, I know that there sounds bad, but competitors, other options that are available in the local community can poach people away with whether it be better pay, better benefits, work from home, kinds of things. And that's going to vary, from area to area as well too. So yeah, without really knowing how the integrated behavioral health infrastructure is like really built, is there like a lot of that opportunities for curbside consultations and warm handoffs and the huddles and all those kinds of things that really build the glue in that sense of community. When people have the sense of community, a sense of a team, it makes dealing with stress and the chronicity of that easier, and maybe much more likely kind of holds folks together. But yeah, I'd be curious about Dr. Runyon's thoughts about that as well.
Mute myself. Hi, Nellie. It's been forever since I've seen you. And I'm not seeing you now, but lovely to see your name. That sounds really hard. It sounds really hard to be a leader in this place where you have had so much attrition and the demand has increased so much. And you included clinicians and community healthcare workers, and Craig made a point just in his presentation that I think I just want to underscore, which is this has not been an equal opportunity pandemic, and it has not hit all of us in the same way. So in some ways, it's not surprising if you employ a lot of community health workers who probably many of them, their experience during the pandemic was much more intense than others. And so in some ways, I think that's one, not surprising. So not taking that as a ding as a leader. And then the other thing I think about too is how wide can the expectations go? How much can they bend, given that it is a time of crisis, perhaps knowing that that is temporary, so that people don't feel like they're doing the wrong thing, right? And so that there's a consistent message around what is and isn't acceptable, because so the individual clinician is being put in those seemingly impossible situations of having to sort of decide who to see and who not to see. And so how can the environment kind of do as much to buffer the individual clinicians in that time in delivering service? That's not an easy thing to operationalize, but that's kind of what I think about in that question.
One of the things that we found among the leaders of behavioral health programs in varied settings that in the course that I was working with was that there was a good variability in how integrated you might call them. And in other words, in some places, there were behavioral health clinicians and they were accessed by referral. There was not a great deal of warm handoff, meaning person to person meeting around the patient and the need, and the primary care person, primary care clinician introducing the behavioral health clinician, and that others were much more part of teams that met as teams and that were on duty to the primary care clinicians and available on the spot. This involves a great deal of variability in how people handle scheduling and how they handle availability and how they handle the types of services that they deliver and how they think about themselves, so that in the ones that tended to work better, the even very needy patients tend to get much more episodic kind of response and to have a less settle in to do therapy. Mm-hmm. And that has tended, not fully, but tended to help them feel engaged, to help the patients feel engaged, but to keep from overwhelming the clinicians. But when clinicians, for instance, spend their entire afternoon hanging out a window, putting swabs up people's noses, as many have had to do in this situation, there isn't a real cure for that level of pressure, I think is fair to say. Our next person has a appreciation of Christine, and I'm going to let you read that. I'm not sure you have to answer a question there, but it's
nice fan mail, though.
Heartfelt, though.
Yes, thank you.
And the last one that we have in front of us, let me make sure there's nothing down further. No. Key unanswered research questions would benefit from additional studies or funding. I think so. I think that we have some pretty detailed assessments of the degree of integration. I don't think we're talking about a six-point scale. I think we're talking about something much more detailed. And we have some, at least one that's been fully validated. And that, compared with the degree of attrition in a particular time, seems to me to be something that would deliver a response that then would beg the explanation. And the explanation would be theoretical rather than data-driven, perhaps. But if the pattern that we're describing holds up, it would be something that would, I think, beg a good deal more study from the health system in general, knowing that as we speak, the whole department of HHS is working on an action plan to make primary care central to the healthcare system as a whole. And there is an openness now for this kind of data at the highest levels. And so it would seem timely. Tina and Craig, did I take up all the space there?
I just want to underscore, in anyone who, on this call or is doing research in this area, it's so common that people sort of stay in their swim lane in looking at these questions relative to a certain kind of health professional. And to Sandy's point, I think research that is going to look across the whole team. Now, whether that's, sort of inpatient or ambulatory, certainly in primary care, but really tries to answer these questions from the perspective of, the physicians, the nurses, the MAs, even, sort of including staff, certainly all the mental health care practitioners, that actually looks at, if you're going to look at systematic interventions, that it's not just an effect on one type of health professional. The secret sauce in all of this is the interdisciplinary aspect.
Folks, we've come to the end of our time, I'm afraid. We thank you so much for attending. We hope this has been useful to you. There will be a recording of this available on the net. I can't give you the address nor the time, but it tends to come fairly quickly. And you could come back to the NCIBH office to find the address on the web in a few weeks. And I hope you'll be with us on the 26th of this month for our next webinar. Thank you to Gina Fatahi, who is our person who makes everything work here. Thank you to Dr. Dobany, who is the director of NCBHI, and thank you to HRSA for supporting the work that's being done. And we hope to see you all next time. Thank you. Bye-bye.